Hello and welcome back to day 2 of this week's Crack the Case. Again, I'm Dr. Nita Kadir. I'm an associate professor in the Division of Pulmonary and Critical Care Medicine at UCLA. This activity is jointly sponsored by National Jewish Health and Bonum CE. This program has been supported by an independent educational grant from Gilead Sciences. So yesterday, I presented a 51-year-old man with a history of kidney transplant who was initially admitted to the medical ward with COVID-19, acute hypoxic respiratory failure, and acute kidney injury. He's now being transferred to the ICU after 2 days of increasing oxygen requirements. So what do we do next for this patient? He's immunocompromised and he has COVID. So let's talk first about supportive care. The patient's currently on high-flow nasal cannula, which is a great initial choice. It's non-invasive, delivers a little bit of PEEP, generally well-tolerated, and there's no need for sedation. In acute hypoxic respiratory failure secondary to COVID, it's also been shown to decrease rates of intubation compared to standard methods. But what do you do when the high flow is not enough? So in this patient, after he arrived to the ICU, his O2 requirements continued to increase. He was requiring up to 90% FiO2 and increasingly tachypnic with increasing work of breathing. So what do you do now? So some might say give a trial of non-invasive positive pressure ventilation, or NIV. So this is a controversial topic, so I want to talk a little bit about the pros and cons. The pros are that it delivers PEEP, it's non-invasive, and sedation can be minimized. The cons are serious though, and in my opinion, often underestimated. It's not comfortable. It generally cannot be used continuously and long-term. It usually makes nutrition very challenging, and most importantly, it does not ensure lung protective ventilation. In ARDS studies prior to COVID, it was actually associated with increased mortality in patients with a P to F ratio of less than 150, so not so great for the more hypoxic patients. The data for its use in COVID has been intriguing though, and has gotten a lot of attention, but it is also a little misunderstood. The Recovery RS trial compared CPAP, high-flow nasal cannula, and standard O2 in patients with COVID-19 and hypoxic respiratory failure. They found that the CPAP group had the lowest intubation rates, but they also had an increase in adverse events, and there was no difference in mortality. So these findings really should be interpreted with caution. It's also important to point out that CPAP was used in this study, not BiPAP, meaning no inspiratory pressure was used, and thus there was a decreased likelihood for delivering injurious tidal volumes. So with all that said, the bottom line about NIV is that if you use it, you should use it with caution. Ensure your patient is able to tolerate it, monitor their tidal volumes closely, and consider avoiding inspiratory pressure and sticking with just CPAP. And keep in mind the impact the NIV is having on other aspects of their care, such as nutrition. In this patient this hypoxic who's approaching near max levels of high flow, I'll typically skip the NIV and move forward with intubation. Intubation in these patients, often challenging, and I always think of these as difficult airways. These patients will typically desat quickly upon induction, so pre-oxygenation is crucial, and both high-flow nasal cannula and NIV can be great for this. Your approach for most patients should be rapid sequence intubation by the most experienced operator with the airway equipment that person is most adept at using. You want that airway to go in quickly and as smoothly as possible. Once that airway is in, you want to ensure that you are using lung protective ventilation, meaning a tidal volume of less than 6 mLs per kilo of predicted body weight and a plateau pressure of less than 30 centimeters of water. So we've known that lung protective ventilation decreases mortality in ARDS for over 20 years, yet we're still not always great at doing it. So make sure to be mindful of this. One more important facet of supportive care is prone positioning. So during the pandemic, we saw a lot of awake proning in patients prior to intubation. However, the data on this practice has been mixed, with some trials showing reduced rates of intubation associated with awake proning and other trials suggesting possible harm. The patients for whom it seems to be the most effective are individuals who are on high-flow nasal cannula and can prone for over 8 hours a day, which is not comfortable and not doable for all patients. If you do attempt to prone an unintubated patient, make sure the patient is relatively mobile and able to easily follow instructions. Also, don't be falsely reassured if their O2 sats rise. These patients are still extremely ill and at high risk for decompensation. After intubation, though, the data on proning is much more robust and associated with decreased mortality in patients with ARDS and a P to F ratio of less than 150. It's actually the adjunctive therapy with the most evidence for its use in ARDS, yet it's still pretty underutilized, although we did see rates improve during the worst of the COVID pandemic. All right, so we talked a lot about supportive care. So now let's talk about therapeutics. What therapeutics would you choose, and at what point would you choose them? So starting with antivirals, let's talk specifically about remdesivir. For non-severe COVID, it may reduce admission to the hospital. For hospitalized but non-critically ill patients with COVID, it may reduce mortality and the need for more mechanical ventilation. When a patient's already critically ill, though, there's no known benefit for its use. This patient was appropriately started on remdesivir when he first hit the medicine boards, so we finished off a 5-day course. However, I would not have initiated it had he been critically ill on arrival to the hospital and in the ICU right away. So now let's move on to anti-inflammatories, starting with steroids. So steroids are indicated for patients with COVID-19 who are requiring oxygen. It is not indicated for patients who are not requiring oxygen and actually associated with potential harm in patients who are not hypoxic. So this patient was on oxygen from the time of arrival, so they were indicated for this gentleman and started appropriately. There is some variability in the type and dosing of steroids, but dexamethasone 6 milligrams a day for up to 10 days is what's been best studied. This patient was on 5 milligrams of prednisone a day at the time of admission as part of his immunosuppression. This is, of course, far less than the equivalent dose of dexamethasone that's indicated for COVID. So the prednisone was stopped at admission and he was started on dexamethasone 6 milligrams a day. If a patient gets more ill, as this gentleman did, additional anti-inflammatories should be added on. And in terms of which anti-inflammatories, you have a couple of choices, either baricitinib, which is a JAK inhibitor, or tocilizumab, which is an IL-6 inhibitor. These are indicated for patients who are on high flow, on non-invasive, or on invasive mechanical ventilation, and also should be considered for patients with rapidly escalating O2 requirements. So this gentleman met a couple of those criteria. He was on high flow nasal cannula at the time of transfer to the ICU, and his O2 requirements were rapidly increasing. Although the NIH and WHO guidelines recommend these medications in this particular situation, there's still a number of unanswered questions. So first, and the issue that's probably most relevant to the patient we're discussing is this patient's immunocompromised, and all of these medications are immunosuppressive. But there are two sides to that coin. So on one hand, immunocompromised patients are going to be at higher risk for developing one of the biggest adverse events from this medication, which is secondary infections. On the other hand, though, immunocompromised patients are also more likely to die from COVID and more likely to have severe outcomes compared to non-immunocompromised patients. And then there's another question. How do you decide between baricitinib and tocilizumab? And it's tough. Most studies seem to demonstrate similar outcomes between the two medications. However, one recent observational study did find a decreased rate of secondary infections in patients treated with baricitinib compared to tocilizumab. So that has, at least for the time being, to me, tipped the scales in favor of baricitinib, especially for this patient who, again, is immunocompromised and at higher risk for secondary infections. Like with many things in COVID, though, data on this topic is likely to evolve, especially now at this point in the pandemic, where we're seeing that probably the majority of our patients who are becoming critically ill fall into the immunocompromised category. So I hope you learned something from this week's case study, and I look forward to you joining us again for another Crack the Case. Thank you so much for joining us today. Please make sure to claim your CME credits by going to the link shown. Complete your post-survey and evaluation, and be sure to click like and follow for more social media CME.